I'm so grateful for our wonderful Right Care leadership that's joining us, and our new colleagues joining us from the American Medical Association in Chicago. I want to welcome you to our 298th gathering of the Right Care Initiative. This started on my desk in 2006, and we had our first statewide gathering in 2008. Since then, many leaders in healthcare have gotten to know each other throughout California, and we have wonderful supporters, wonderful collaborators from across the state. I want to particularly thank the pharmaceutical industry for getting us through this international health crisis with our pandemic, and just say that I believe that our gathering every 2 weeks, or even more often than that, through the pandemic has been an important support system for our healthcare leadership who's really been struggling. So thank you to the California Department of Public Health for their support. Thank you incredibly to UC Berkeley for being the mothership of the Right Care Initiative. We have support from Los Angeles Public Health, Blue Shield of California, the Stroke Awareness Foundation, the Tennis Getter family, the Dupereau family, the various UCs across the state, University of California Schools of Medicine, Pharmacy, and Policy have all been very important. Public health, of course, is where I sit. And the dean of UC Berkeley School of Public Health was just instrumental in figuring out how to do this. He was the first person I called when I looked at the blood pressure data and said, hey, my mom died of hypertension when I was 15. How is this possible? We know how to control blood pressure. And he was just all in from day one. He picked up his phone. He was at a meeting in Chicago with the American Hospital Association. And he said, I will lead your technical expert group. And he's had my back every step of the way ever since. So thank you to the California chapter, the American College of Cardiology, and to our amazing academic partners, including Stanford and the University of Southern California, along with the University of California schools across the state. We have wonderful long-term support from Johnson & Johnson, Genentech, Novo Nordisk, the Health Trust, Boehringer Ingelheim, Amarin, and Amgen. Next slide, please. I think all of you know me by now, and I am very happy to be the convener of this group, to bring these amazing minds together to do this important work. We are seeing some success, and I'm very grateful to my many academic mentors that taught me how to use data to drive positive public policy change. Next slide, please. I'm also grateful for the chief lawyer of the state of California in health, who said, yes, it's perfectly safe to collaborate around improving clinical quality. He was my right-hand man. He is not well enough to join us in our meetings anymore. He's very up in age now, but he created our motto, and that is that we compete against disease and not each other. Next slide, please. We love Warren Barnes, amazing, brilliant man, not only a lawyer, but also when he retired from the state became the minister of Grace Presbyterian. So he brought his heart and soul to the state of California to improve patient care for many decades, extremely famous man. And he was with me as we gathered our technical experts to create these goals, which I'm thrilled that the American Medical Association now shares, which is to control hypertension, control cholesterol to LDL less than 100, and also for diabetic patients, hemoglobin A1C less than 8. We foster coopetition amongst competing health systems, and we mostly gather by Zoom these days. We're starting to have an inkling that we might be able to gather in person again if we're lucky enough that Omicron provides a lot of natural immunity for our public. Fingers crossed. Next slide, please. Our last major public event was co-hosted by the Centers for Disease Control, head of preventing heart attacks and strokes for the Centers for Disease Control, Betsy Thompson. Her position is now led by Janet Wright, who we all knew from her role in the Million Hearts program. This is one of my favorite photos of all time because you see all these smiles of people who are so amazed by Professor Bill Baumer, cardiologist from UC Davis, who is our chairman, as he's teaching about the new guidelines for blood pressure control. So Bill, thank you for always finding a way to get effectively into the minds in such a way that physicians will actually change practice. So next slide, please. Dr. Baumer has quite an amazing career, and he brings his heart and soul into everything he does. He's just, he has trained probably more cardiologists in the state of California than anyone else, and he lends his support to not only physician organizations, but little nonprofits like the Right Care Initiative, the California Chronic Care Coalition, and many other wonderful organizations, including the American College of Cardiology, where he's the past president of that. And he also is a quality improvement expert leader with the state of California, with both the California Department of Public Health and also the Office of Statewide Health Planning and Development, which has just been renamed, and I haven't memorized their new name. So with that, next slide, please, and I'll hand it to you, Bill.
Thank you very much. It is HCI is the new department of OSHPAD for information. So we're delighted for Right Care to look at a number of measures or metrics that really help us to improve outcomes throughout the state of California, but especially in the counties that are listed here, which were the initial focus counties, starting initially in San Diego, as Hattie said, moving on to LA, Sacramento, and now lastly, Santa Clara County. And as Hattie mentioned, our goals for the parameters that we're following is to get actually 80% for that. We're not quite there at 80%, but you can see that we're getting close to that in some of our counties that we see, Sacramento, LA as well. For blood pressure on the top, the bottom line again shows our attempt to get what we call yellow or gold bars to the top, over 80% for all of those counties for individuals with diabetes, which now carries an additional risk factor for those individuals who have diabetes to make sure their blood pressure as well as their blood sugar is controlled as well. And we also look at cholesterol control as well for that. So you can see we have had successes, and we've had some areas where there is what we would call room for improvement. So the great thing today is we're going to talk about some initiated measures by the American Medical Association to facilitate or help improve our ability to get or improve those measures to our goal of 80% or even higher if we need to. So the program today is how do we fill some of those gaps that we see here in the yellow bars or the gold bars. Next slide. So we have done that in the Right Care Initiative through a number of tools and protocols and policies, and that they are represented here in the triangle, which has on the left areas of proactive outreach, which include active clinical pharmacists on the team working with the California Department of Public Health and the Surgeon General office on that as well. Looking at patient-centered practice redesign. How do we actually go into a practice and implement changes that have success in achieving our improvement in the measures that we showed earlier? Using a variety of protocols, and we endorse all guidelines, including ACC, ADA, and other guidelines that are national in the US for getting better control of blood pressure, cholesterol, and diabetes in that population. Next slide. So today we have a great presentation, and we happen to have two excellent presenters that we'll introduce soon, Karen Kemetic and Michael Rakotz, who are both vice presidents of the American Medical Association. And I would say if we have two vice presidents, that's the equivalent of one president. So we have the equivalent of the top leadership of the American Medical Association, and we certainly want to welcome them today because they've come up with an innovative program in helping programs, including our groups in California, at improving things, including blood pressure control targets that we'll see today. So we're delighted to have those presentations. We'll have a little bit later a presentation by Scott Flynn, and then a Q&A section that you will have to follow for that. Now, the two speakers, first speakers, are going to present innovative ways of additional tools for filling those gaps offered by the American Medical Association. And I'd like all of our participants today, while you're listening to their lectures, to look up in the corner at the chat box, click on the chat box, and just put in your opinion as to whether your group or healthcare system might be interested in the tools that are being offered today in the presentations. If so, we'll keep a list of the chat box for that and provide that information and feedback to the two speakers so they can get an idea of the participants that we have today. And we have currently 67 participants. How many in a survey would be interested in accepting or further working on getting access to the tools that are presented today? That'll give them and us some idea of how much help this could be. Now, I'm not promising the world. There's a lot of individuals on participating today, and there's limited bandwidth of what the AMA can offer at this point in time. But I think it would be interesting to see how many of our actual healthcare providers on today would have some interest in participating or working with the American Medical Association in the tools that are being offered today. Next slide. So remember to go on the chat box and just enter whether your group has an interest in that. So Karen Kemetic is the Group Vice President for Improving Health Outcomes for the American Medical Association. She is, as I said, a Vice President directing the focus of the MA to prevent chronic disease and improve outcomes for patients and populations, beginning with hypertension and pre-diabetes. She has an extensive education and experience in this area for that. She's also a assistant professor at the Northwestern University program, and received her PhD in health policy and administration, which I think is going to help facilitate the program and presentation today, concentrating in economics, always important as we talk about healthcare and the availability and access of healthcare. Our other speaker, next speaker, is Michael Rakotz, who is also, as I said, Vice President of Health Outcomes for the AMA, or American Medical Association. and also a clinical assistant professor at Northwestern University. He oversees efforts to develop and implement, again, national quality improvement initiatives aimed at improving blood pressure and preventing cardiovascular disease. He is the AMA's clinical lead of the Target Blood Pressure, a nationwide multi-year initiative in collaboration with a number of organizations, including, he was brought to us not just by the American Heart Association, but by the Million Hearts program, which provided the introduction for he and his staff for that. He certainly has experience in this, is an active clinician, and has a lot of prior experience in both administration and patient care, which makes it or facilitates the program and presentation today. So with that, I'm delighted to start the introduction of our two vice presidents. And remember that two vice presidents is the rough equivalent of one president in leadership and ability. And we're not going to count or add up in Bitcoin today. We're just going to do in credentials and experience. So we look forward to this presentation. And remember, if you have access to chat box and are interested in this program as you hear the presentation, just click on and add your 2 cents to it. We can always use those in our Bitcoin program. Thank you very much.
Well, hello, everyone. I'm Karen Kimetic, and thank you so much, Dr. Baumer. I am going to tell our president that Mike and I add up, so I appreciate that. And thank you so much, Hattie and Dr. Baumer, for inviting Dr. Rakotz and I to speak with you all today. And it's also good to see Dr. Flynn. I have the pleasure of serving with Scott on the CDC's National Hypertension Control Roundtable. I also just want to take one moment at the start to really express my deep appreciation on behalf of myself and the AMA for all of you who have and continue to care for so many during this pandemic. We see in pictures and words the toll that it takes on so many of you. And while you're also trying to keep your family safe. So please know that our appreciation goes out to all of you. And as was said, you know, we share your goal. We absolutely share your goals, and in particular with a focus on blood pressure, which we'll talk about today. And we've watched you from afar for quite some time. The success of the Right Care Initiative is very impressive. And we're delighted to be here and share with you a little bit about what we've put together to see if it might be, as Dr. Baumer said, helpful to some of you on your journeys. So with that, the next slide, if I could. So I'm just going to set the stage and then really get out of the way and let Mike tell you about this work that we offer. And then we hope we do have some time for conversation if that allows. So next slide. I don't need to tell this audience much about the current state of cardiovascular disease and blood pressure control in the US, but just to maybe set the tone for Mike's presentation. Next slide, please. We all know that unfortunately deaths due to cardiovascular disease are rising. So we are going in the wrong direction with deaths from CVD. And in the next slide, we also all know that controlling hypertension could actually prevent more CVD events than really any other intervention that's been studied. It's quite remarkable. And that's why we're all here today and why you started the Right Care Initiative with a focus on hypertension. Next slide, please. And unfortunately, we also know that hypertension control rates are falling. In fact, we're back to along the 2005 levels. So heading in the wrong direction in terms of deaths rising and blood pressure control rates falling. Next slide, please. And we also know that it appears that blood pressure control has been falling during the pandemic. Now, some people can say that much of these data points, we have a lot of missing data during the pandemic, but there's also some publications. One came out from in circulation from Cleveland Clinic and Quest which also showed declining blood pressure during the pandemic. And there'll be more research coming out, I'm sure. And so the numbers might get moved one way or another, but I think it's fair to say we still have work to do as a nation in blood pressure control. And so next slide. And the other thing that I think probably haunts all of us is that we still have these stark inequities in blood pressure, both in terms of prevalence and outcomes. Black adults having the highest prevalence of hypertension compared to white, Asian, and Hispanic adults. Asian, Black, and Hispanic adults having worse blood pressure control rates than white adults, and mortality from hypertension and associated diseases being 4 to 5 times higher in Black than in white adults. And I know we feel that every day. And so our work is to improve blood pressure for adults in this nation, with particular emphasis on these populations who still see these stark inequities in prevalence and outcomes. Next slide, please. So really just setting the stage with the sobering data, but then also just to share that, so this is a major focus area of the American Medical Association. We have a team of about 50 individuals who are committed to this work. We share your goals. I report to our board every quarter. How are we doing in helping healthcare organizations like those of them on the call today to meet the blood pressure goals that you have with your patients? We take this very seriously. We hold ourselves accountable. And it continues to be crazy, if you will, to think about the fact that in 2022, here we are, and we still do not have data for this #1 risk factor for CVD events, that we don't have that data readily available to all of you at your fingertips. When I was back at the University of North Carolina and studying economics, and we all knew about the Bloomberg terminal, right? That was on the desk of every CEO of every major auto company in America, right? They'd get all that information at their fingertips. Why do we not have that available to all of you for the leading causes of death in this country, and particularly right now, blood pressure? So that's what we kind of thought in our minds as we began to build this program. We always center it on evidence and research, which Mike will explain. But really, we're here to just say, can we provide to all of you, be partners with you, and give you perhaps some data, some training, some coaching, some tools to help you improve blood pressure for your patients, as I know you're all working so hard to do. So with that, Mike, I will pass the baton to you.
Great. Thanks so much, Karen. And I just want to say thanks again for everybody that committed their time tonight to attend. Really appreciate it. Next slide. So I want to talk today about our MAP-BP Quality Improvement Program, and I'm going to go through a little bit of the history about how and why we created this high-impact quality improvement program to improve blood pressure control. And I want please keep in the back of your minds that while we're focusing on blood pressure primarily today, in development and testing in parallel with this quality improvement program for blood pressure control, we're working on cholesterol control, diabetes control, and preventing type 2 diabetes. And we're hoping to have parallel programs in place so that these can be done as a more comprehensive approach for CVD to reduce the impact of heart attacks and strokes in the US adult population. So with that, I'll say that about 10 years ago now, the American Medical Association started collaborating with Johns Hopkins Medicine. Peter Pronavos' team. Peter Pronavos, widely recognized as one of the pioneers in medicine at using checklists in healthcare. And we also worked with members of his team, Lisa Cooper, notably, who at the time was running the Center to End Health Disparities in Cardiovascular Disease. And together with their teams and the Improving Health Outcomes team, Karen's team at the American Medical Association, we created a quality improvement framework that we knew would apply to most conditions, but we created it to work specifically to improve blood pressure control. And that's the MAP framework, or the MAP Quality Improvement Framework. MAP stands for Measure Accurately, Act Rapidly, and Partner with Patients, Families, and Communities. And as it relates to hypertension, specifically in high blood pressure, measure accurately to obtain actionable blood pressure measurements to diagnose and assess blood pressure control, act rapidly to treat uncontrolled high blood pressure when indicated, and partner with patients to support them in activation and self-management, including adherence to treatment and non-pharmacological treatment or healthy lifestyles. Next slide. So we took this framework, we really developed it and created the program at a variety of 10 practice sites in both Chicago and Baltimore, everything from solo practices to large academic medical centers, to really prove the concept and fine tune both the framework, the checklist that accompany them, and what would end up being the quality improvement program. So for each component of the key components of the framework, M, A, and P, we have an evidence-based strategy and action steps to help execute on that strategy to make it easy to implement in clinical practice settings. We provide supporting tools and resources, including checklists, assessment tools, protocols, to help with process change in clinical practices and to really help try, again, to make this easy to implement without disrupting existing workflows by modifying them to optimize them for better care for patients. We do all of this with clinical implementation support with our doctors and nurses and quality improvement specialists on our team, collaborating with those on the healthcare organizations teams. And we use data to drive improvement. So you hear that a lot. I know that's a big part of Right Care, really leveraging data to create performance improvements. And so we use metrics, quality improvement metrics, process metrics or measures. We visualize them in the form of easy to view dashboards that are 1 or 2 clicks away at all times, putting them, as Karen said, in the hands of those who need them with the touch of a button technically, along with a suite of monthly reports that can really help improve care being provided to patients. So that's the MAP-BP program. Again, high impact quality improvement program that takes about 6 months to execute in a healthcare system or setting. Next slide. So what is the program? I mean, we talk a lot about MAP-BP, but this is a busy slide, but it really breaks out and breaks down what we're trying to accomplish in each of these 3 areas. So with Measure Accurately, our evidence-based strategy, we really want to obtain accurate and representative blood pressure. So accurate blood pressure, meaning that the blood pressure measured in the person that is estimated is very close to their blood pressure in their artery at the time that it's being measured. So good technique, proper patient prep and positioning, using automated, clinically validated devices, typically upper arm devices are preferred. And representative. So we use measurement protocols because we're trying to get, rather than a single snapshot in time office blood pressure, we're trying to get a series of blood pressures when indicated in an office setting. They're a little more representative about what a patient's true blood pressure would be outside of the clinical setting, because we know that those would correlate better with outcomes. So these are the 3 action steps. So using an accurate device, an automated validated device, proper patient prep positioning and technique, and using a standardized measurement protocol that's fine-tuned for the existing workflows and environment. So again, one of the important parts of this program is we try to be as non-disruptive as possible to existing workflows, but we do try to optimize them for success. Act Rapidly really focuses on initiating and intensifying treatment, both pharmacologic and non-pharmacologic therapy, but we're really focused on getting people the treatment that they need in a timely fashion. So using evidence-based treatment protocols, using a team-based approach, promoting the use of single pill combination therapy, and frequent follow-up. Guidelines have been recommending follow-up every 4 weeks with someone with uncontrolled blood pressure for quite a long time, but we don't often see that, or we don't see it as often as we should in clinical practice settings. And finally, the P, partner with patients. We want to support our patients in self-management. We want to improve adherence to treatment. We really want to see activated patients. So the idea that we spend time working on collaborative communication strategies, something we worked on extensively with Johns Hopkins, assessing and addressing adherence to treatment, using proven non-pharmacological interventions, and some people just say promoting healthy lifestyle changes, but guidelines use this terminology for very specific reasons. And then we have a strong belief in self-monitoring or self-measured blood pressure monitoring, SMBP, as a way to engage patients in self-care. And also really it can be used in all phases. I'll talk about that a little more in a few minutes. Next slide, please. So one of the key components of the program, again, is having that data, using these metrics to drive improvement. And what I want you to look at on the right-hand side of this slide is that you'll see for each key component, for M, A, and P, we have a process measure or metric that goes with each component, at least one, to help track what's being done, so that we can try to identify gaps in care and close those gaps. And so it can track your progress over time in a transparent way. Preferably, the organizations typically decide how the data is shared with participants, with physicians and other providers at the site level, at the provider level, patient level, and system level. But these metrics, so the first one that we use is our key outcome measure. You're probably very familiar with. Most people use, whether it's NQF18 or the HEDIS measure for controlling high blood pressure, or the CMS measure, the UDS measure. All these measures look at blood pressure control rates. Confirming blood pressure, again, looks at adherence to a measurement protocol. I'll go through all these specific measures in a few minutes. Therapeutic intensification looks at what percentage of the time does somebody with uncontrolled hypertension have a treatment intensification using pharmacotherapy performed. And then we look at what happens to blood pressure on the visit following the treatment intensification. Are we seeing the expected drop in systolic blood pressure, which is essentially a proxy for medication adherence? And finally, are we seeing those with uncontrolled hypertension follow up within 30 days as recommended? So those are our process metrics. Again, we try to make them available to system leaders, to physicians and other providers, to practice managers, quality improvement specialists, pop health specialists, and care coordination. The organization decides how who has access to what data, but we promote the idea of transparency, as you do, I'm sure. Next slide. So does the program work? So I've described the MAP framework, I've described the MAP metrics and how we implement the program and support health systems in doing this over a 6-month period of time. And the answer to that is where we study this, that this works very well. So we call it a high impact program because you can expect an absolute 10% improvement in blood pressure control. So that's 10 percentage point improvement in control rates. And in this study that we did in 16 very busy primary care practices in South Carolina, they saw 16,000 hypertensive patients in a 6-month period of time. And when you look at their baseline blood pressures, the tall bars on this graph, you'll see that blood pressure control initially was about 64%, rose to about 74% by the end of the program at 6 months. And at that point, we withdrew our clinical support, our coaching, but we left the dashboard and the data accessible to the care team members in the hopes that we could sustain that 10% improvement. And what we saw at 12 months, 6 months after we withdrew our practice coaching and clinical support, was that they maintained over 90% of those gains. So we saw statistically significant improvement in the metrics in each component of the program, in the M, the A, and the P. Although admittedly, we would have liked to have seen stronger or higher improvement, greater improvement in treatment intensification. That has been a challenge, not only in the United States, but around the world. So this is something that we'll talk about in a few more minutes. But the sustainability is something that you don't often see in a lot of quality improvement programs. So this is something that we're really excited to disseminate. And so that's exactly what we did. And on the next slide, you'll see that we've started to spread this program across the country over the last 5 years. And we're now in about 25 states. And rapidly spreading. You know, Karen said, she talked about our ambitious goals. We really feel like we can reach, and we are planning on reaching 30 to 50 million people with a diagnosis of hypertension in the next 5 years. Our goal is to move 5 million people who are currently uncontrolled to goal blood pressure. We think we can do that, and I'm going to continue to tell you specifically how we think we're going to do that. Next slide. So now I'm going to go do a little bit of a deeper dive into our process measures and how we have them visualized in the form of dashboards and our monthly reports. And I think this is really, again, what these are components of the program that really make it, I think, somewhat unique and very powerful. Next slide. So we realized very quickly when we created the program and started to roll it out that we really needed to have a dashboard development or software development team on board. And so that is a service that we now provide. We've got a team in Greenville, South Carolina. Brent Egan leads that team clinically. We've got several other really experienced experts in software development and quality improvement working with us and our Improving Health Outcomes team in our South Carolina office. So we provide this as a service to the organizations that we work with. And I'll say that the AMA funds our work, all of our work. So we don't charge for this service to construct these metrics and have these dashboard visualizations and monthly reports available. We can do it in 2 different ways. We can either host it on the AMA AWS web servers, or we can potentially build it in an Epic system or a Cerner system. We're looking into being able to deliver that embedded into other EHRs as well. Currently, we're working with Epic and Cerner. We have an Epic programmer and a Cerner programmer on our team to help do that. So the whole point of having this dashboard is to make simple, easy views of these key metrics available and really useful monthly reports on treatment intensification and giving the users the ability to stratify these data by race and ethnicity. And I'll show you how that's done in just a few minutes, but that can be done very quickly to again, identify gaps in care and then use program recommended tools, resources, and content to try to close those gaps. We have several filter functions that I'll give you a graphic display of in just a few minutes. And the idea here that again, you've obviously know the benefit of the idea about transparency that I think Kaiser really 20 years ago was doing this for a long time, really sharing data so that you can high performers can work with lower performing sites and providers can work with each other in a way that, again, as Hattie said, not necessarily competing with each other, but working together to overcome barriers to success in preventing heart disease. Next slide. So the outcome metric, the only thing that I want to say about this metric or quality measure is that while most will show control rates using 140/90, because that's what's in all the quality measures, you saw the slide with Dr. Balmer talking about the 2017 ACC/AHA guidelines and the new control rate goal of less than 130/80 for most patients. So we simultaneously will show blood pressure control as a percentage using less than 140/90 and using less than 130/80. And while most organizations are still using less than 140/90 to report on quality, we are seeing more and more that really want to treat patients and target less than 130/80. And what they're finding is by targeting less than 130/80, even if they don't get there, they get many more people below 140/90. So their quality scores are improving, as you would expect from that. The other thing that I think is important, and this is true in our recently updated national quality measures on blood pressure control, is that we allow the use of out-of-office measurement in the form of telemedicine visits and self-measured blood pressures to count towards meeting these goals as they should. I think we were late in modifying. We as a country were late in updating our quality measures to reflect that, but I think especially during the pandemic, we see the very high value of being able to track blood pressures outside of the clinical setting. Next slide. So that's our outcome measure. Now let's just to get a little bit deeper into the process measures. We recommend, as I mentioned earlier, a measurement protocol. And the idea here is that for the metric to track and check on this protocol, we recommend repeating a blood pressure whenever the initial blood pressure is high. Again, this has been guideline recommended to do 2 or more blood pressures on 2 or more occasions for probably now really since JNC 7 and earlier. There's a very good reason for that. I mentioned before that we want representative blood pressures that represent a person's true blood pressure, both in and outside of the clinical setting. So we track how well teams are adhering to that protocol. So this is a process measure that really is tracking the clinical team's ability to repeat blood pressures when they're high. Now, you'd think that this would be easy to do, but we've got a lot of bad habits to undo. And I think the norm in the United States, like the rest of the world, is really to just take a single blood pressure, often without having people rest and without proper patient prep and positioning, not using validated devices. All of these things are problematic. But the goal here is to track adherence to that protocol. And again, even if sites want to fine tune how they go through the nuts and bolts of implementing this protocol, this is a very good metric. We set the goal at 50%. We've seen as high as 80% in one organization, but typically this measure starts between 10 and 15% for most health systems that we work with. And some can achieve the goal of 50% of the time being adhered to, and some can't, but it's something that's really nice to have the ability to track over time. The idea with all these process measures is that we look in these dashboard and monthly reports indefinitely to see if we might be slipping in an area over time. And I'll show you what the trend bar looks like for all of these measures. We can track trends. And if you start to see a trend in the process, you can sort of intercept that and target a refresh, say on measuring accurately as it is here, before you see it impact the outcome. So this is one of the reasons why I think our dashboard is so effective. So next slide, we're going to talk about the act rapidly metric, probably our most important metric here. And for this tracks treatment intensification, the percentage of patients with uncontrolled blood pressure at their most recent encounter who had an antihypertensive medication class added. Now, this is, this surprises some people. This is a measure that we've updated several times. We're trying to change prescribing behavior here so that it has significant impact on outcomes. And what we found is that that people very quickly notice that, hey, you're not talking about increasing the dose of an existing medication. And we're not. We're talking about giving numerator credit here for people who actually add a new class of medication. The reason for that is we know that if you add a new medication class compared to doubling the dose of an existing medication, you'll see 3 times greater blood pressure lowering than if you just increase the dose or double the dose. This is true at half standard dose, this is true at standard dose, and this is true going to high dose. That the benefit here is very small compared to adding a new class of medication. The other problem is that we know from nationally reported data and modeling that people really, in the United States, people receive treatment intensifications when indicated about 13% of the time. That means you probably have to have roughly 7 visits on average before you'd receive an intensification. The average time between visits nationally is about 14 weeks. And so if you do the math on that, somebody would likely wait 2 years to get a treatment intensification. And if they're going to wait 2 years with uncontrolled high blood pressure, their risk obviously goes up substantially. Nobody wants that to happen, but those are the numbers. And we'd like to see triple the effect of a treatment intensification by adding a class rather than a 2 to 3 millimeter increase, say, when you double the dose of an existing medication. And I'll show you later that based on our treatment intensification reports that we've looked at, and we've looked at millions of patients, and this is widely recognized that many people with uncontrolled high blood pressure are on no medication or 1 medication when we know that they will need 2 or more medications to get to goal. So this is really important. So I spent a little more time here. Hopefully that makes sense, but it's something that we're not setting the goal at 70 or 80% of the time somebody needs to have a new medication class added. We're setting the goal at 30% because most people are closer to 10 to 15% when they start at adding a new medication or even adding a medication and increasing the dose. So we really focus on medication classes. We can talk about this in the discussion. Next slide. Finally, we've got 2 partner with patient metrics. The first one looks at the percentage of patients who on the visit following an intensification have a 10 millimeter drop in systolic blood pressure. This is a proxy for medication adherence. If you see somebody back and they don't have that drop in systolic millimeters of mercury, they may not be adhering to treatment as recommended. So we've used this measure. It seems to resonate really well. It ties nicely into the treatment intensification metric. And so this is one that we've been able to move the needle on as well. And next slide, you'll see our final partner with patients metric, which is about 30-day follow-up for those with uncontrolled high blood pressure. What percentage of patients who are seen or have an encounter virtually with an uncontrolled high blood pressure have a follow-up blood pressure measurement within 30 days? We do this for obvious reasons. We really need people to be seen quickly. We know that the risk of death from uncontrolled high blood pressure goes up in as little as 6 weeks after it's been diagnosed. So, we really can't afford to wait as long as we're waiting. There are a lot of soft reasons for people not coming in. We call them soft reasons for prescribers not intensifying therapy when indicated. And again, this is something that has been guideline recommended for a very long time. So those are the metrics. And on the next slide, I start to show what this looks like all put together. This is a visualization of our dashboard, just the basics. We try to keep it as simple as possible, never having more than 4 or 5 metrics on a page. We can compare a provider with the average blood pressure control. For example, you see here on the left, 51%. We can compare that simultaneously on this same visualization, what a provider is scoring versus what their practice site is, what a provider is scoring compared to what their system is, 2 providers compared to each other. So this is really customizable with just a click of a button. And we find that this visualization is really good. With the click of a button, you can request a patient level report. And for any of these measures, you can get a list of patients who meet or don't meet these metrics. So very useful in clinical practice for care management, care coordination. I'll show you what that looks like in just a sec. When you're looking at the dashboard in your EMR or on our hosted web version of this, when you go to the next slide, please, you'll see that we also have a really important filter function. And this is absolutely critical. We think that people can filter each of these metrics from outcomes to processes looking at ethnicity, race, gender identity, age, and comorbid conditions. And this is something that can be done very quickly with the touch of a button. And then again, on the patient reports, you can really break this down and sort in more detail so that you can stratify. The idea here is that you're looking for inequities in care so that you can try to eliminate them. And this has been a really helpful function. Next slide. This is what the trends look like. This is just adjacent to that visualization that we just showed in the dashboard. You'll be able to trend. You can see month-to-month changes. This is blood pressure control rate. And while that's normally calculated with the 12-month rolling averages, we make all of our metrics available with 12-month rolling averages. And then with the touch of a button, you can see month-to-month change so that you can track the improvement that's being coached and being achieved over time. This has been really helpful for systems that we've worked with as well. Next slide. And this is what a patient level report looks like. This is what really makes everything actionable. So if you have a care coordination team, if you've got an RN assigned to do this, or if a provider has time, or even a medical assistant, this is a patient level report looking at blood pressure control. Anybody who's read has a systolic greater than 140 or a diastolic greater than 90. They can be sorted very quickly by who's uncontrolled and who's not. And you can target outreach to bring people back in, or have follow-up blood pressures based on, say, systolic blood pressure, how far from goal they are, when their last visit was, and you can, again, stratify based on race, ethnicity, gender, comorbid conditions, age, whether or not they have a diagnosis of hypertension or not, all can be looked into. And if you look on the bottom row here of these tabs in Excel, you'll see all the metrics are available to do the same type of sorting. So a very actionable report here. I'm going to go over two other very useful reports quickly before we wrap this up. On the next slide, you'll see a gaps in care report. Now, many health systems and EMRs have health maintenance sections. They are not used as often as many would like to see them used, but this is a report that prints every morning based on the day's schedule, prints up for each patient who's coming in, looking at key indicators, blood pressure, BMI, hemoglobin A1C, and LDL, 10-year ASCVD risk. And it's just displayed very quickly and briefly in a 1 or 2 page report for people coming in that day, so that you can just look for who might, you can see the blood pressure, all the medications prescribed, as well as suggestions for what might be missing. But it's just something that's quick and easy. Although this can be done in the EHR, it's just not often done as well. And with a team-based approach, again, whether you've got a nurse doing this, a pharmacist doing this, this can be a very valuable report. If desired. These are all options, so you don't have to be overwhelmed with reports every month, but I think reports are one of the strongest components of the program. And finally, on the next slide, we really believe in turning the lights on about what's happening with medication prescribing, because I think it's, for whatever reason, there's a phenomena that physicians tend to overestimate the quality and aggressiveness of care they're providing. And so, we find consistently this histogram looks at the number of medications only for people that have uncontrolled high blood pressure. So what we often find is that 40 and sometimes up to 50% of patients who are uncontrolled are on no medications or one medication. This is how we graphically display that. It tends to get people's attention. Again, this report can be done per provider, per office site, or for the whole health system. And then on the next slide, we break it down in a little more detail, looking at what exactly is being prescribed, what doses are being used, our appropriate use of thiazide-like diuretics being used, like chlorthalidone and indapamide, or what percentage is hydrochlorothiazide, what percentage are single pill combinations, et cetera. So very, very important and useful tool for really making it very transparent, again, what's being done compared to what people may think is being done. So it's just provides that data that make things very real very quickly and offer opportunities for improvement. Next slide. So I'm just going to make it go to if you can go to the next slide, please. I just want to say that, at the AMA and with the American Heart Association and Million Hearts, the Centers for Disease Control, we all strongly believe that a key strategy for improving blood pressure control is self-measured blood pressure monitoring, or home blood pressure monitoring. And we wrote a policy statement with the American Heart Association and the CDC. This was published as an AHA policy statement in 2020. it's a policy statement, and I think it does do a good job informing on policy. But it reads like a scientific statement, so it's actually quite easy. It's a great review of the literature, and I think it gives a lot of insight into how to effectively use home blood pressure monitoring in clinical practice, as well as making strong cases for policy change. In addition to that, on the right-hand side of the slide here, you see a 7-step quick guide that our team put together very quickly after the pandemic hit. So that if on the left-hand side, this policy statement's about 18 pages, it's readable for a publication, but it is 18 pages. This 7-step quick guide's about 4 pages, 3.5 pages, can be read very quickly and used by clinical teams. It's available on the AMA website, very useful. People, I have the URL here that you can take a look at your convenience. And so if we go to the next section, the next slide, I want to talk a little bit about what this would look like to implement MAP at your organization. So we bring our experience and expertise in hypertension, improving blood pressure control, our clinical operations team, quality improvement team, and IT teams, working together with your organization's complementary teams. We collaborate to personalize the program. And while we have typically, we have a playbook that we like to use that uses a team-based approach that I keep bringing up. We customize the care processes to try to be as non-disruptive as possible with existing workflows. So we try to fine tune and tweak where we can so that we're not creating what feels like a heavy lift for the teams. And we support the organizations throughout, from pre-implementation planning to the launch of the program to supporting the program over 6 months. And of course, we're available after that as well. And the goal is that whoever participates in the program, receives their dashboard and monthly reports, will have those indefinitely so that they can continue to improve. And again, I'll remind you that while we focus initially on blood pressure and have the evidence to support the success of our blood pressure control program, we're working on the same for cholesterol, diabetes, and pre-diabetes. Next slide. So one of the things that we like to do in an effort to try to meet organizations where they are and leverage what they're already doing, we do a current state assessment that we do together to try to understand where an organization is in this process, what the culture of hypertension and blood pressure control is at the organization, how they're leveraging their EMRs, is their clinical decision support already there, is there a treatment protocol in place? So we really try to learn from what's happening before we fine tune it a little bit to optimize it for the organization. On the next slide, you'll see how important it is for us to try to identify a physician champion and a site champion that's typically a medical assistant or an RN at each of the sites. Some organizations like to go system-wide from the beginning. Some like to identify a small number of pilot sites to test this before they roll it out system-wide. But we know that these are critical. I'm sure you're very familiar with this. These are really essential to have engaged champions at each site and an engaged executive sponsor and physician sponsor of the program overall at an organization. Really makes things go a little smoother. And we coordinate with the clinical education teams, transformation teams, QI teams, and pharmacy teams at these organizations to make it truly a team-based approach. Next slide. And while I've showed you what the dashboard looks like, just realize that while we're in the planning phase, we typically receive data to build these dashboards or build it within the EMR. And we go through a lengthy validation process to make sure that the data that's being shown is accurate. We all know how critical that is. We also have a strong focus, of course, on data security as well to make sure that there is no concern over breach. Next slide. And once we understand what an organization tells us what their culture is, what their workflows are, what they think they're doing, we actually have on-site assessments, not just to look at the environment that they're working in, but we used to do these in person. We do them all virtually now, but we often understand, often what the organization finds is that although they have protocols in place and processes in place, they're not always followed. And different members of the team sometimes tell us different stories about what's happening compared to what, say, system leaders think is happening or what is supposed to happen. So obviously this is invaluable to understand what's really going on inside a clinical operation so that we can help identify any bugs in the system, so to speak. Next slide. And again, we use we strongly favor the use of a train the trainer model for sustainability and to scale the program after we leave. So everybody that we train in this program, particularly provider champions and site champions, are trained to roll this program out and sustain it, not only at their site, but if we try to enable them to be able to scale or spread this program within an organization across the entire system, whether that's in the same zip code or whether that's across a state. Or even, we work with the fourth largest health system in the country. They're in 22 states, and they implement the program. We've empowered them to do that and train their clinical teams and quality improvement teams to do that. Next slide. So again, we coach and train and plan, and we get to program launch where we train clinical team members as well as physicians and other providers. We collaborate with pharmacists. We make sure they all attend the overview and training specifically for them. We have physicians training physicians and providers and pharmacists. And we have RNs and typically working with RNs and medical assistants on the care team side. Post-launch, we support the implementation for about 6 months, phone calls, typically now webinars and phone call support with Zoom or Teams or WebEx happen about every 2 to 4 weeks at the discretion of the organization to make it convenient and fit into what QI programs they're already running. We, again, really leverage the metrics, data reporting, and dashboards to drive improvement. I can't say enough times how this really, truly is a data-driven program. The ability to get the data and make it available is really critical. Next slide. So that's it's about 40 minutes for me, and that's all I had planned on saying. I have not been looking at the Q&A or chat, but we're going to have a moderated Q&A session now with Karen and I to answer any questions that you have. And please do ask questions. We really we love talking about this and what our experience has been, and we'd love to hear what your experience has been. I know this is a very seasoned group and experienced group. So thank you again for letting us present this information to you.
So Mike, that was a fascinating presentation. We're all delighted. And there were a couple of questions that came up on cost, and I had some questions on cost as well. Number one, I think both you and Karen have specified that there's no cost to from AMA for the participation in this program and your personnel and tool options and toolkit that you offer for it. But one of the things in the Measure Accurately is obviously having a automated blood pressure measurement, which I think many of the larger healthcare systems probably already have because they're a little bit more efficient and they went to those early on. But there may be some smaller practices that don't have automated systems. And the other that I think is actually critical when I'm dealing with patients is the self-measured blood pressure. And the self-measured blood pressure for me means they have to have a blood pressure system for measurement at home. And I think that's actually better than clinic or anything else. Have you found a way of getting reimbursement for if we go for 50 million individuals for blood pressure, and I think that's a reasonable goal, and we're at $20 each, that's $1 billion in cost for that. So many of our health systems don't have that money, and many of our patients don't have it. Have you found an effective way of getting reimbursement in the current insurance plans for obtaining that valuable component to the self-measured blood pressure system?
So those are really great points, and we could probably talk for a couple of hours about each one of them. But I'm going to I'll try to go quickly through these and maybe have some additional conversation. So the first part of your question, so yes, there's no cost for our clinical support services or our dashboard development services. But an organization, if they are typically if they're using Android devices, and some use all automated devices, AOBP state of the art, that is rare. It's a mix of oscillometric devices and some wall-mounted aneroids, but occasionally we see some organizations that literally only measure blood pressure with portable aneroids, which, as I'm sure you know, are the least reliable. So it's important that we talk about at least how blood pressure measurement technique needs to happen to get accurate measurements with those. So the cost of upgrading to automated office blood pressure devices in primary care settings, can be up to $500, in the neighborhood of $500 per device. And that's something that we understand, we acknowledge that. We help organizations figure out how to procure accurate, validated devices. If they're going to spend the money, we want to make sure they get the right devices with 4 cuffs available in different sizes so that they have a chance to do this. And we can talk about the case of improving quality scores that may come from that, which often is the case from transitioning over to AOBP and seeing the lowering of blood pressure, a more representative blood pressure can often improve quality scores. And in some cases that can lead to better reimbursement for the organization. But that's an important point. We don't buy devices for organizations in clinical settings, but we've seen a lot of really great results and improved outcomes. And a big component of our improvement does happen from better blood pressure measurement technique and the use of automated devices. So that's, I'm happy to talk about other costs that are not for our services and implementing. Most organizations can implement without hiring new FTEs, and that's the norm. Occasionally, we'll see an organization hire a 0.5 FTE RN or convert a 0.5 FTE RN or MA to oversee the clinical aspects of the program from a care team standpoint. You make a really great point about the importance of self-measured blood pressure measurement devices. And we have invested thousands of hours over the last 5 or 6 years to try to improve the quality of home blood pressures taken by patients. Incentives for health systems to use self-measured blood pressure monitoring. We actually created and submitted, and these were accepted by CMS's physician fee schedule, 2 CPT codes for care teams to use to train people in self-monitoring blood pressure, and then for managing self-monitored blood pressure using home blood pressure monitoring without digital tools and equipment. We created 2 codes that could be used, and both were allowed to be used during the pandemic. These codes were approved and launched January 1st of 2020, but because of the proximity to the pandemic, they were in some ways lost behind all of the energy that went into surviving the pandemic. We also have the nation's first US validated blood pressure measurement device list that took us many years to stand up. So like many countries in Europe and Australia and other parts of the world, we have a list of devices that anybody can go to look at whether or not the device was clinically validated prior to coming on the market in the United States, whether it has an extra large cuff sizes and some of the features there. So a very important part of this. We wrote, of course, the policy statement that I shared. So we really do believe in this. But to your point about coverage for these devices, while we've been successful in getting CPT codes developed and out there for training and management, we have been working for the last 2 years with the American Heart Association, collaborating together to try to get a non-coverage determination for self-measured blood pressure monitoring devices for those who need them. Now, we haven't succeeded yet, but we also are studying Medicaid coverage, which is rapidly expanding across the country, state by state. And we want to make sure where that coverage currently exists, that it's high quality coverage so that it covers quality devices along with XL cuff options. And these are all really important to our team. We're working with our advocacy team and again, trying to figure out solutions. So there is some coverage and more coverage for services, training services and management services, as well as devices and through Medicaid. CMS with some comorbid conditions, but this is something that we're really working on. Karen, I don't know if you want to say something here.
I was just going to add, because the question came up in the chat. So to find this list of devices that are validated, there is an independent website called validatebp.org. I'll put it in the chat and really encourage you and your patients to use it. And then to Mike's point, we want Medicare to coverage these devices, and we've got the national coverage decision submitted to them. We want every Medicaid program to cover them and the physician services. We've got about 13 right now who cover it. And we want, frankly, every private health plan to cover it for their members. You can't compare blood pressure to the pandemic. I get that. But how can we leverage this thinking in the nation, where now we have private health plans are covering COVID tests, right? Many have been covering for years the home glucometers for diabetes. We got to get these home blood pressure devices sort of on that list of what everyone needs to stay healthy.
Yeah, and just to briefly say, where and this does relate to the pandemic a little bit. When you look at, we all think that using out-of-office measurements, and most experts from around the world agree with us and agree with you, Dr. Bomber, that this is a better way to measure blood pressure. But during the pandemic, when we look at 2019 blood pressures compared to 2020 blood pressures and death as a result of heart disease, we see in white adults that death from heart disease went up 2 to 4% during the pandemic, 2020 compared to 2019 on a month-to-month basis, 2 to 4% increase. But in Asian adults, in Black adults, and in Hispanic adults, that number went up 20%. So a relative 20% increase from 2019 pre-pandemic to during the pandemic. And we know that the only way to measure blood pressure during the pandemic, for the most part, reliably, was out-of-office measurements. And I say this because there's a question in the chat that came in that I want to address quickly that talks about the importance of dashboards and blood pressure having to incorporate out-of-office measurements into them, as well as relaying the data from a home blood pressure monitor to get into the EMR. Now, this is something that we have believed strongly in for a very long time. So much so not only are we trying to work with EMR vendors to try to make these structured fields in EHRs available, when we've been doing that for a really long time, trying to make that happen, we do use out-of-office measurements in our process and outcome measures in our dashboard. And we have an entire team at the American Medical Association focused on solving the issue of relaying data from people measuring their blood pressure at home and getting it into either initially a cloud-based server and eventually directly into the EHR, like many who are working on this, but we have a whole team that in a parallel to our team that are working on that. So I just wanted to address that in the chat. We couldn't agree more with that, the importance of being able to relay data back to care teams, because we know that home blood pressure monitoring alone does not improve outcomes, but home blood pressure monitoring in conjunction with clinical support and co-interventions does. And that's the way that it needs to be done. So there's a way that home blood pressure monitoring needs to be done to be effective in improving outcomes. It's one of the reasons we wrote that statement.
Thanks, Bill, for getting the question and answer session started with that excellent question, and for our presenters so far. So, Karen, I would challenge you on the pandemic and the blood pressure. One of the things that we brought up in the Right Care initiative several times was, with the exception of just a few days during the peak of the previous COVID waves, people were still dying from heart disease every day at higher rates. And so the challenge for all of us is, how do we get the rest of America to view heart disease the way they were viewing COVID, obviously. So as I listened to your presentations, one of the things that struck me is the fact that most healthcare organizations now have high quality electronic medical record systems that are often missing these types of useful analysis of data to be able to free our forebrains to be able to do the work that we are struggling, to do, because we don't have those excellent displays of the data. And I guess the question I would ask both of you is, in the past, organizations like the American College of Cardiology advocated for standards for echocardiography PACS systems and cath PACS systems. Is there a time where we can't just wait for the marketplace to sort this out, where Cerner and Epic and the other EHRs continue to make tools like you've created as high-priced options that are often priced out of many healthcare organizations' budgets? Is there a time where we need to advocate for national standards for EHRs so that they include these types of healthcare metrics for our chronic disease prevention programs?
Yeah, and I can jump in and start. And what I'll say is that's a very timely question, because we've been on the phone over the last 2 weeks with a large governmental agency that's been very prominently featured in the pandemic throughout. I can't say which one, probably. They are working on precisely that right now with the Office of the National Coordinator. So with ONC, they're working on data standards for out-of-office measurements, which is a component of what you're talking about. It's not a comprehensive solution, but once those data standards are created and put into play, we should see the improvement happen more quickly. We were hoping to go the route of working with the vendors directly and then having them come to a HIMSS meeting and through the EHRA committee actually disseminating those standards, on their own, as they're obligated to do. But we had a lot of trouble getting that to take off, the first one. And so by creating national or federal standards, which I think are going to be here very soon, I think that's going to help speed up the process. We absolutely need these. There's no excuse not to have them. We are way behind in this, and we need to take big steps to try to solve this. We need to have structured fields. We need to have people understanding the importance of averaging. We need those averages to be able to be used in quality measures, so that this all works together, so that the incentives align, so that we can take better care of patients. But I think that's a really important question, and something that we're working hard to solve, along with organizations like the American Heart Association, the Center for Disease Control and Prevention.
And I would just add, Mike, if I could, Dr. Sky, and that's one of the reasons why we offer to provide these map dashboards and reports out of your own EHR, right? So we have on our staff, under Mike's team, a Cerner experienced expert and an Epic expert, because we realize you all can't be paying extra and extra for all these things, but we figured out how we can sit down with you and we can help you get these reports out of your existing systems. We got to work it at all angles. So we're trying to work it directly with you, work the organizations who have the standards. And, I think it's time we do go back to the Cerners and Epics and have this conversation again. Every time we're there, they'll say, well, our clients are not asking for this. Well, next time maybe we'll go with 3 of you, clients of theirs, and say, yeah, they are.
Well, I mean, my take on it, as I've dealt with it, because we're in the military, as many of you know, we just inherited a new version of Cerner, and it's a pretty bare bones program. The way I've started to look at this more and more, and I'm curious to know what your opinions are, is these are FDA approved devices, and if we're saying that they are capable of being used to provide healthcare, I think we have to start mandating that they have some of these basic essentials in them, because we're selling the whole country short. And then I'm going to transition to another question, because I don't see any other questions in the chat box. I know Bill will think of another one here in a second, but why did you choose a cutoff of 70 for your goal, when, as you know, Kaiser a decade ago started achieving numbers significantly higher, that even 80 to 90, and many of the organizations that present their data for the Right Care organization are achieving 80s and similar percentages. I'm just curious where 70 came from.
Yeah, so 70 is not a hard number. That was illustrated for graphical purposes only. But I will tell you that one thing that we do, we let the organization set their own targets, and here's why. So if we go to a high functioning organization that's at 76% when we start, absolutely, they're going to set 80, 85, or 90% as their target. That happens all the time. We don't want to push that on them, because we don't necessarily understand their history, their culture. We want to make sure that it's an audacious goal that they work hard to try to achieve. But the other place, we do a lot of work in the safety net. So we work in community health centers across the country, federally qualified health centers, and networks of federally qualified health centers. Often in those centers, while we do have many that are high performing, we see often 40% control rates, let's say, not uncommon. So to set an 80% goal across the board might be ambitious, but it feels, what we've heard when we get feedback from organizations is that they feel like it's not achievable, and they almost, I don't want to say they give up ever, but it's so far away they don't think they can do it. So if they've got a 45% control rate and they want to set a 65% target for that year, see if they can hit that, that's awesome. We support them. We help them do that. If they want to go higher, we help them do that. But it's organizational. And to that point, Million Hearts for the next 5 years, they just announced, on a partner call today, that for the next 5 years, instead of picking a hard number, they're looking for 20% improvement from current state. So that is what now the Million Hearts team is focused on. And so that is something that's, we're trying to find out what the right answer is, but currently we leave it in the hands of organizations, and we consult with them to come up with a challenging goal that would have, good impact, and try to find that balance there. Great question, though. I did not mean to convey, unlike the other measures where we do actually help them propose what could happen. For control rate, we really have to leave it up to them, especially if they choose the 130/80 control rate, because those numbers are usually down in the teens to 20%, as you know, much lower, much different.
Well, still seeing no questions. I'll ask one more. I'll twist on the question that was in the chat section. I understand the cost is zero, but if you were a commercial product, do you think you would be competitive to the products out in the marketplace? Looking at all the resources the AMA has put into producing this.
Well, I do think for the product that we put out, comparing to so many others that are no longer with us, that have not weathered sort of the storm, so to speak, I do think we put out a competitive product, and I do think it's great. I will tell you that I have literally been told by the CFO of a top 10 health system in the nation, I'd feel a whole lot better about this if you charged us $500,000 a year to do this, because I feel like because you're giving it away, it's hard for us to assess the value in the marketplace. And I know that sounds crazy, but literally that really happens. And it's not infrequent that happens. People are very, I'll say skeptical that why would the AMA be doing this? And I don't think they really understand, the mission of the AMA that goes back to 1847 to promote the art and science of medicine and the betterment of public health. We truly are trying to improve the health of the nation. That is our mission. That is our goal for our team and for the AMA. But that's not widely understood or recognized. So we do have some bumps in the road there with organizations questioning what we're really doing. The AMA's got a long history, a little bit bumpy at times. So we've got to do a very good job at conveying why we're doing this, and that it can be effective and that there is value in it. But we're also studying the ROI for using home blood pressure monitoring. We published a few papers on that in the last couple of years. And we really want to figure out what is the ROI for improving blood pressure control on a population. I mean, there's a return on investment from a health standpoint, but also from a financial standpoint. And that's something, we have 2 health economists on our team and a whole team of data analysts. We're really trying to make some progress this year towards figuring those things out. Everybody wants to know that answer to that question. Here.
Yeah, and I'll just add, we do speak to plans and say, could you think about new ways to incentivize this work to improve blood pressure? So don't worry about paying us, but how do you incentivize and provide additional support to the healthcare organizations that might have to buy the AOBP devices? So, we're engaged in those conversations right now and trying to move that as well.
So Bill, I see your hand is up.
Yes, sir. I will lower it right now. So Mike, I was fascinated with your introductory recommendations, which included, we talked about the automatic blood pressure for the institution, self-monitored blood pressure, very important. You also threw in there single pill, which we have used in the past in some of our NIH trials, a combination pill. And as you know, there are a number of studies out on the poly pill, which includes not only blood pressure, but maybe even cholesterol reduction, et cetera, for that. But when I look at patients coming in and review their medicines for reconciliation, I almost never see a combination pill for cardiovascular disease. And I wonder, in your programs, in introducing those tools, how often did the program provider accept a poly pill or a combination pill as their, and how easy was that? Or is that still something that's hard to actually get that swallow for U.S. healthcare?
Yeah, this is a really good question, and globally, where they approve formularies and poly pills, I think it's a different story. But great question. So I think it's really important for everybody to understand that by using single pill combinations, you're going to see better adherence by the patient to taking the medication, lower blood pressures, and better outcomes. So, I think a lot of people don't realize, when you look at the studies, compared to single pills independently, if you use the medication in a single pill combination, you're going to see a 20% reduction in death. You're going to see significant reductions in things like heart failure, right, and stroke and heart disease. So the outcomes are significantly improved. But to directly answer your question, right now, it looks like about 7% of cardiovascular medications are used in combination. That's pretty scary that we can't do better, even though we know what those benefits are. I think there's a gap in what providers understand and know, but we think that we can make progress here. We have dedicated significant resources in better understanding what it's going to take to change prescriber behavior in this area. And we have so many combinations that are generic and low cost, but we don't have people using them appropriately. So we're studying the science of messaging even to try to get our message across better. So that's a project that we're working on this year. We hope will have some impact, but this is one of our greatest challenges. I bucket this under treatment intensification or treatment in general. We're working, with colleagues at the George Institute who put out the quad quarter, study. There are 2 drugs coming to market in the next 2 years that are triple drug, ultra low dose combination. These drugs are incredible. The quad therapy can get close to 80% of people to goal at 1 year. And it's a quarter dose quad pill. 80% of those that take it single pill get to goal at the end of 12 months. But that doesn't mean that we can get prescribers to use it. That's going to be a huge challenge outside of a clinical trial, something that we are laser focused on trying to improve. But it is a huge barrier and a challenge. Now, Kaiser, famously went from prescribing lisinopril HCT, I think it was something like, 20 times a month by its providers at the beginning of their initiative to 10,000 times a month. And we obviously saw what the impact was. They can't directly correlate that with that, but the fact that they have a treatment protocol that starts with single pill is I think really important in itself. And now when you look at guidelines around the world, you'll see, if you look at Europe, 2018 for hypertension, most patients are recommended to start on dual combination therapy, a single pill combination pill. And if that doesn't work, they go to a triple in a single pill. And they believe that strategy alone would get them from 40% control on the continent to 80% control over time, just by using single pill combination therapy. So this isn't I would say it's emerging, but we've known it for a long time, but I think it really is emerging. And what everybody's trying to figure out is how can we change prescribing behavior to make this work? And I'll tell you what I think a big part of that answer is, and I'd be curious to hear if the PharmD on the call agrees, but pharmacists using pharmacist-driven protocols, nurse-driven protocols, following a protocol. And this is something that Kaiser will tell you when you talk to their people who lead their hypertension program. The reason that they're able to get single pill combinations on board per protocol are the pharmacist co-management of hypertension and the pharmacist-driven protocols and the nurse-driven protocols, nurse practitioners using these protocols. This is something that I think is dramatically underutilized in this country that we think would, I think would help, that we're hoping to prove can help. And we're trying to figure out better ways to leverage both pharmacists embedded in clinical practices and community-based pharmacy with collaborative practice agreements. We've got to figure that one out. Again, we're gonna dedicate some resources to try to study that a little more over the next few years. But if there's anybody who wants to comment on that, that's a pharmacist.
Sure.
I'd love to hear. I'd love to hear.
Sure, I will share with the group that when we approached looking at our performance with the management of patients with hypertension, what we did was to use the playbook that was presented by Kaiser at the Right Care Initiative at the University of Best Practices in Los Angeles. We took many aspects of that program. The one part of the program that my providers, both the IPA and our employed medical group physicians, push back on was the fixed dose combination of medications. That was on both sides of the house. They were quite open to looking at accurate measurement of blood pressure, combating clinical inertia, having the patients come back in 2 to 4 weeks if they weren't at their blood pressure target. But when it came to the fixed dose combination, I got this.
And that is our experience nationally with many health systems. But when we engage the pharmacists, which we do tactically, they seem to have great control. I mean, you look at a place like Virginia Mason, where pharmacists manage hypertension, diabetes, and high cholesterol, and their quality scores are phenomenal. If you look at the Barber studies, and Ron Victor, comparing the second Barber study to the first one that he did. In the second one, he had pharmacists in the barbershops, and the first drug in on that protocol was, a combination, an ARB calcium channel blocker combination with an add-on thiazide-like diuretic. And so starting with that combination appears to be a critical factor. They saw close to 25 millimeters of drop in systolic blood pressure very quickly. I think that was due to 2 reasons: a great formulary and pharmacists using that formulary regularly. So no question. And when you look at other countries, you see similar success stories where they can implement, PAHO is having great success in Latin America using, these types of protocols.
I think part
India
of
as
the
well.
feedback that what I got from my providers was a concern about the ability to titrate a medication or
Mhm.
having a side effect from one component,
That's,
because it's fixed dose.
yep. Yeah, we hear it
And
over and over and
those
over
are-
again, but
Quite frankly, those are the kinds of things that I heard back in pharmacy school over 30 years ago.
yeah.
So, I don't know if it's just part of the training or what, but
Yeah,
definitely what you're saying is what I heard in my face-to-face meetings with my providers.
Yeah, fear of adverse events tops the
I
list.
just
There's no
wanna
question.
say,
But the systematic review and meta-analysis looking at that
incredible
shows
to
no
hear
more.
this discussion.
Yeah.
I just want you to know that our next presenter, who will be introduced by Joe Sky, is a great blood pressure champion who started out as, I first met him in our work in San Diego, and he heard, gosh, all the way back in 2011, a presentation by multiple pharmacists about the better results that we get when pharmacists manage the three metrics that we're both laser focused on: LDL 100, blood pressure, and A1C8. Scott will tell the story himself about how he tested it with one physician champion as a skeptic and was convinced by his own experience in his medical group. So, Joe, why don't you do the formal invitation, and let's hear from another one of our hypertension champions who's going to be leading up some great work for the Centers for Disease Control, in addition to his leadership with the Right Care Initiative.
Well, thanks, Hattie. I think you've already introduced Scott in a great way, but let's do a little bit more. So it's been a pleasure to know Scott for several years. He and I share a military background. We've both been operational physicians. Scott with the Navy SEALs, and myself with Air Force pilots. And we like to tease each other, but tonight I'll forego that and we'll jump to the important things, which is that after his Navy career, Dr. Flynn moved on to be an executive leader and is currently a regional medical director with Blue Shield of California. And one of the things that I respect about him is he keeps his clinical credibility by continuing to provide patient care himself so that he doesn't lose track of the challenges that we all face. And tonight we're going to get to hear his presentation as the new lead for the National Hypertension Control Roundtable Partnership Team for the CDC. Scott, it's a pleasure to have you present tonight.
Thanks, Joe, and I appreciate you passing up the opportunity to give the Navy grief, which would be appropriate. And also to echo what Cindy was talking about, and Hattie, about pharmacists on the care team. Yes, I was a skeptic also back in the day, and when I was at my group, we decided to go ahead and give it a try with a pharmacist instituting the hypertension algorithm and working with one of our internists. He had a hypertension control rate around 50%, kind of the national average. And with the help of the pharmacist and the protocol, he got up to 77% in 6 months. So, and I know we were talking about 80% control. Is that a realistic goal? The answer is, yeah, maybe. It depends on what you're going to do and how much you want to put resources into it and time and effort. But it certainly made me a believer in it. And one of the things that I like using to tell my providers about when they are hesitant about it, it's like, oh, let me see if I understand this properly. You don't want a pharmacist helping with hypertension, but you're more than happy to give them anticoagulation and let them mess around with warfarin and Pixaban and all those things that can kill people and all that. But you don't like that one, so you're more than happy to give that up, but not hypertension. Really? And they kind of go, oh, geez, okay, I see what you mean. So anyhow, that's the story about pharmacists on the care team and hypertension algorithms, and definitely a big believer on it now. About 4 years ago, at the CDC, at the Division of Heart Disease and Stroke Prevention, Betsy Thompson, was there, and they were trying to strategize about what in the world are we going to do about the cardiovascular disease. We're kind of stymied on this. It's the #1 killer. It's been the #1 killer for a long time, and we don't know what we can do to help control it. It's part of the CDC's task to help with the health of all Americans, and that's the #1 killer. And so they looked at that, and then as our friends at the AMA just pointed out, what's the #1 modifiable risk factor that controls cardiovascular disease, and that is hypertension. All right, well, if it's the #1 modifiable risk factor and it's the #1 killer, then maybe we ought to do something about it. Around the same time, the Surgeon General at the time, Jerome Adams, had also issued a call to action to address hypertension control also, and he asked for the nation as a whole to get to a hypertension control level of 80% within 5 years, 2025. So there is both a time and a number that was laid out there from two of the leading forces in our country, the CDC and the Surgeon General's office. Now that's a what we call a BHAG, right? Big, hairy, audacious goal. But if you don't dream big and look for those things, then you're never going to get anywhere. So it was interesting when I heard the 20% improvement as something that Million Hearts just came out with. If you think about that, if you're at 50% now, 20%, that's a 10% improvement going from 50 to 60%. That's not a BHAG. I understand getting folks and not getting them too depressed when they get started about that. There's no way I'm going to get there. But you certainly can do better than that, I think. And that's something I think we really need to talk about as we're looking at things and how we inspire people to try to get better at this. Next slide. So how do you get better at this? Well, we were talking about it, and we came up with 3 basic pillars here of what you need to do to get better at hypertension control. One is to make it a priority. As we talked about recently, certainly COVID is a huge priority. But as alluded to, except for a few months, heart disease was still the #1 killer. And here we are, and we're still there, and we're still all focused on COVID, but it's still the #1 killer. How are we going to make this a priority? How do we cultivate community supports? This is not just a provider issue. This is also a patient issue and a community issue. So how do you engender those healthy communities that can help make a difference in lifestyle modifications to help control hypertension? And then finally, yes, even though it is a community issue and it's a priority issue, it is still a provider-patient issue at its very basic. How does that provider-patient interaction go? Again, listening to the AMA presentation when they talked about physician inertia and taking 2 years to titrate medicines to get to where you need to go. That's one of the principles of right care and something that we're looking at as a national objective to try to get folks under better control in a much more rapid fashion. And one of the ways to get there is with an algorithm and using pharmacists on the care team. Next slide. And if you look at the factors, again, it's bigger than just the care team. There's a community that's involved with this, your providers, the patients and their families, and there's policy things that can happen on the national, state, and local level. How do these things all come together to make this ideal? So as we get there, as a nation, we can get to 80% control. Because that is a big number nationally, and you can perhaps do pockets of it. Again, Kaiser's doing it. My old group, we were doing it. There's a bunch of groups within Right Care that are doing it. But it's not across the state of California, which is where my focus is right now, but also nationally when you look at it. It's a very disparate population with a different healthcare system that folks can access throughout. So how do you do that across the nation, across the country, and get things so that you can have better, equitable, quality care that's being given? Next slide. So since it's not just a care team, what did CDC do? They said, we're going to convene a roundtable, and we'll invite the Knights of the Roundtable to come together, and let's see if we can solve this. Next slide. So they came together and developed some guiding principles. There's the mission, you can read it. The vision to extend healthy life for all, and the values. And two of the values I'd really like to point out is one is health equity. If you think about it, if you look at the goal of getting to 80% control nationally, and you don't address health equity, you're never going to get there, because the hypertension control in some of the subpopulations is so low. Unless you address that, you could have 95% in other populations, but as a country, you're never going to get to that 80% control collectively. So that absolutely has to be a key and essential thing on how we address hypertension control in this country. The second one I wanted to point out was the evidence base. There are a lot of things that we do because that's the way the doctors that trained us taught us to do, and the people we work with trained us to do. What is the evidence base that goes with it? What are the supports that go with it? Like you were talking about the self-monitoring of blood pressure and the research that goes behind that to show that as a best practice. Great, and let's show the evidence and let's figure out a way to best implement it. So that is part of the effort also. Next slide. The CDC convened the steering committee for this National Hypertension Control Roundtable. You can see some of the members that are there. As noted, the American Heart Association is one of the key and critical, as is the AMA, as they are showing now that they are putting forth a lot of effort to this through the presentation you heard tonight. And a lot of folks are really engaged. Next slide. And what is the plan going forward? So this has recently just come together. There are focused on the areas, where do you think you can have the biggest bang for their buck? Where is that expertise that we have within members who can come together and help us get to where we want to go? How do you collaborate across that large diversion of sectors that is there? And then, of course, how do you scale it? That's one of the things we discussed with the AMA efforts. You're doing this program, but is it scalable? Can you get to half the groups in the country, the provider organizations in the country, for them to do this? Can you get to 20%? Can you get to 80% of them? How do you scale these things and make it so that it can become best practice and be able to be used across the country? Next slide. So there are two action teams that have been formed by the CDC. One is the programs and practices. And we've had some people that are here tonight that have already signed up for that action team. And the second one is the partnerships team. And the idea of the partnerships team is to bring together pharmacists, providers, government organizations, employers, employer groups, insurers, and patient advocates to figure out ways that we can attack these other areas that are going to be important to getting to our goal of 80% hypertension control by 2025. I am helping to lead the partnerships one, and I know that Jerry Penso, who's been mentioned before, he was co-chair with me in San Diego back in the day. He's with AMGA. I know he's participating in the programs and practices one. There's about 12 people already signed up, 12 organizations signed up for that. And we have 2 that have already signed up for partnerships. But what we really want to do is let you all know what's happening there at the CDC, and then encourage you to participate in this as we get up and moving and start working on what we're going to do for our interventions and how we're going to expand this across the nation. Next slide. And if you're interested, that's how you sign up. It's really easy. It's just an email, hypertension80@chronicdisease.org. Anyone have any questions? Very well. Thank you all very much.
Scott, thank you for being with us even after a bit of a struggle to make this date work for you. We had so many questions going around how to utilize the various free resources that are being made available by the American Medical Association and also the Centers for Disease Control. And I'm wondering how closely those are aligned. And that might not be a question for you, Scott. It might be Karen or Mike.
Well, I'll tackle it first. One of the things that is obviously happening is the AMA is participating in this effort with the CDC. So not only with the work that Karen and Mike are doing, but also, again, different ways, which is excellent work. So how do you take those best practices that you're trying to implement at the provider organizations and scale it and get it out to more organizations as we move forward? That's just part of it. And again, that's just focused on the one pillar, that's the provider pillar. What about the other two pillars? How do we get folks aware and involved and understand that blood pressure really is a big deal? It's the number one risk factor for the number one killer. How many times can you say it until people get it? But it really is important. So I think the AMA efforts definitely are supportive of what the CDC is doing and vice versa.
Yeah, and what I'll say is that these organizations like CDC, AMA, AHA, the National Association of Community Health Centers, they all lead with science first. They're all guided by science. So, and what we like to say, and we have been working with Million Hearts team at CDC from the beginning, from inception, that our programs, tools, and resources are not competitive, they're complementary. And they will tell you that, we will tell you that, American Heart Association will tell you that. And so many of our tools and resources are featured on the Million Hearts website. They like to convene multiple organizations and have very usable tools and resources. Some of the, for example, treatment protocols available. Not only do they have our treatment protocol, they've got Kaiser's treatment protocol and the VA's treatment protocol and the CDC Million Hearts AHA protocol. So they are absolutely complementary. And can be used together because they're guideline concordant and science driven. They should work well.
Now, I'll just add, we really, we talk to each other a lot, so Mike and I were talking to Janet right this morning, we're constantly talking to each other to try to leverage what we can each do, right? I mean, CDC, right? And Million Hearts, which is CMS and CDC, right? They're not going to advocate to themselves to get coverage for Medicare on devices, but we can do that, right? So AMA and AHA, we took the lead on submitting that national coverage determination decision to CMS. They are not going to necessarily, CDC will not recreate MAP, but they introduce us to potential partners. So that's really how we got here today. Janet and Hattie were talking and saying, hey, maybe some of you in this initiative might be interested in the MAP program. So we wanted to share it with you. And the head of Million Hearts just introduced us to 5 healthcare organizations who might want to be part of MAP BP. So we try to very much to leverage sort of what they can do in their role, what we can do in our role, and everybody. So it's a lot of conversation going on pretty regularly.
I have a question
I'll
about
take the prerogative on. Oh, go ahead, Joe.
How do you decide if an organization is capable of benefiting from the MAP BP program? Do you find that sometimes organizations just don't have the resources or the ability to get the resources needed to be able to use what you have? For example, the clinical pharmacist or enough staff to be able to dedicate to the program?
Yeah, so another really great question. And what we really believe is that all health systems, private practices, and everything in between, solo practices can benefit from implementing the program if they're able. Even an organization like Kaiser will tell you that they're using, the MAP framework and leveraging components of the program to benefit. But to your point, from a readiness assessment standpoint, we don't have a universal readiness assessment. We talked about a current state assessment and site visits that we do. We assess operational readiness to implement the program. But it's a really good point, and we've been really challenged during COVID because of the competing priorities of organizations. And we had our biggest year ever in 2019. And we, close to 20 health systems and over 1 million people going through the program. We were just picking up speed, and then the pandemic hit, and we had a very quiet 2020. Things started to pick up a little bit in 2021, and we're extremely busy headed into 2022, where we probably will exponentially increase the number of organizations we're working with. So, and that's a reflection of the organization's readiness to participate. But we don't have hard data on that. We don't have one readiness assessment tool that we've learn from that we can successfully do that assessment with the organization, but we're trying to figure that out. I think it's a really important point. We're learning as we go there.
And Dr. Sidney, I see your hand is up. you want to go ahead and unmute yourself?
It's very complicated because I'm on my phone because I couldn't hear you guys, and I can't get video. But
Well, we can hear you now, so go ahead.
Yeah, I wanted to make the point, and I'm sure everybody's thought about it, is how important it is to get to young people, young adults. We, showed in the cardio study, which I've been involved for a very long time, that over 1% of the Blacks in the study developed clinical heart failure by age of about 40. Almost all of them had early hypertension, in their young 20s to 30s. Even in Kaiser, I think probably around the nation, we don't do as well in controlling blood pressure in younger adults. And I just wonder what kind of messaging you're thinking about in regards to that issue.
Well, I can jump in. I'm not sure who the question is addressed to, but I can tell you that we agree, and the CDC is really going out front trying to target that segment of the population for that exact reason. I think they were surprised when they got that analysis of surveillance data of from NHANES and really broke it down. That I believe the biggest surprise was, I think, in the 35 to 54-year-old group, where there was such a gap in blood pressure control that was leading to morbidity and mortality, that I think surprised them how great that was. So they are, we are working together, following their lead. They're promoting this nationally, and we'd like to get much lower and eventually even to primordial prevention. But we're, we'd love to be able to get there and get into younger ages and even the pediatric population. I agree that there's no question we need to have earlier interventions that work, and we're not very good. That is a segment of the population that we are not very good at helping at this point with blood pressure control. I agree with you. Thank you for bringing that up.
Yeah, I would just add, we have a coalition right now with AMA and AHA and the National Medical Association of Black Physicians and the Association of Black Cardiologists and the National Minority Health Institute. And we sat down, it was the last in-person meeting I was at before COVID hit. We were all in Atlanta together, and, just what you said, Dr. Sidney, we said, we got to do something here. And so we have a national initiative to try to reach Black women and their squads, to bring attention to them about the staggering data you just described, and to try to engage them in self-measured blood pressure. So that's going on right now across the country. And maybe if we're invited back, maybe in 6 months, I could share some data on what's happening there.
Yeah, and just speaking for the work we're doing on the CDC, intensely aware of that. And that's part of the healthcare disparities issue that we're trying to figure out how to better work on. The disproportionate mortality, morbidity that's associated with Black Americans due to strokes and heart attacks is well noted and well documented. We got to do better, figure out a way to do better with it.
I will take the challenge to mention coronary calcium, since Hattie is always challenging me to do that as a cardiologist. So it's great. We got Steve Sidney on the call, and we've already mentioned the cardio study, and he already pointed out the fact that we should recognize the earlier interventions necessary for some of our fellow human beings. And of course, for all of us, diastolic heart failure is an under-recognized problem that presents after years of unrecognized or undertreated hypertension. And then the same with coronary calcium, that when we've done the coronary calcium in young people and it's present, we have to get more aggressive with it. So that leads to the question, I didn't catch an age for emphasizing control of hypertension. How young do you go when you bring this intervention into an organization?
If that question is addressed to me, it's we classify, we work with adult population. So 18 is typically where we set the, we don't actually set the cutoff, but that's the definition that most organizations use. We haven't gone into the pediatric population at this moment in time. We're hoping to eventually, but 18.
Okay, great.
Yeah, and if we could master 18 to 54, we really have gone a long way. It's one of the biggest areas where
sure.
Treatment intensification is not great or optimal across the board, but in the lower age groups, meaning 18 18 to 50, it's even worse. Missed opportunities.
I also just want to raise the issue, another disparity, and that is the disparity in women getting guideline-based care. And I think one of the reasons you see in the aqua lines behind me that women's acute myocardial infarctions fell much faster than the navy blue lines for men, because we were constantly raising the issue of women's experience with early cardiovascular events. So I want to make sure that we are focused on women in those reproductive years. They're wonderful teachers, they're wonderful nurturers. Can we get home blood pressure monitors into the hands of the mothers of America to help take care of the whole family's blood pressure? So we have another blood pressure champion on online with us here on video. Ed Yu, can you unmute yourself and talk about your impressive work there at Palo Alto Medical Foundation? Ed Yu is our co-chair for the Bay Area and is the Chief Quality Officer for the very famous Palo Alto Medical Foundation Medical Group.
Well, thank you, Hattie. You're also kind and really very excited to learn about the continual efforts that all of us are doing to promote this. I will be first to say that blood pressure control is a area of emphasis for us, and it's also an area where we see the disparities. And frankly, one of the challenges in this space is that hypertension is not one of the sexiest conditions to treat, right? People's attention tend to go elsewhere. However, as we all mentioned, the critical components of the downstream effects, we don't do it well. And that's an area that we continue to emphasize that within our care teams about this, and also how do we impact to make sure that patients have attention. When I hear this talk, it keeps reminding me about the thought about why we call hypertension the silent killer. And the effort that we have to do to let patients say, well, I don't feel anything. I'll give it time. That inertia, particularly, there is clinical inertia from the treatment end that we're addressing here, and also how we also engage the patients so that they don't have the inertia on that as well is one of our focus areas that we have. Therefore, I just want to call one of the challenges we try to address is how to engage patients so that they ensure that they do follow up when we do an intensification. In our work that we have done, we have seen that sometimes the take rate for patients to follow up is not as good for some other conditions. They cancel, they don't show, we keep on reaching them. And then at times, then they don't always follow through. And that has been a challenge. And that'll be one question I have that for the participants here about, are there particular thoughts or interventions to ensure patients do adhere, and with a follow-up is one question that we have that we'll love to learn and share from all of you. We are very attracted to the team-based approach. In our model, we don't have a significant clinical pharmacist on our team. Our team-based approach is leveraging a more allied nurse practitioners and a physician assistant to help with the care team with that, just a different approach. But again, the same concept of leveraging a care team concept to impact that. Again, just want to end up by just saying that this continues to be a focus here for my organization, and I look forward to kind of learning from you all about any tips and tricks that you have for the patient engagement side to keep them engaged and then follow through with these 30-day follow-ups that we are encouraged to do. And I see Bill Baumer's hands up, so I'll toss the floor to you. And you're still on mute, Bill.
Thanks, Ed, for that comment. Mike and Karen, I had a question related to we've all said it's important to start blood pressure control early on. I mean, it's too late once you get heart failure to alter a lot of it. So we want to start very early. We have a group of individuals, females, we talked about sex, who are followed early on who may have hypertension during pregnancy or pre-pregnancy or post-delivery. Those individuals that I'm speaking about are not followed by often family practitioners or by internists. They're followed by OBGYN. And those clinicians actually take care of them for much of their early life while they're, capable of having children or having OBGYN situations. And therefore, in your experience, have you found that OBGYN individuals will feel comfortable taking over blood pressure control and management if you have assigned a pharmacist who, in fact, can increase the dose and things like that? Or do they feel really uncomfortable in general with hypertension, and you have to make a referral out of that comfortable practice for the patient to a new practitioner that is family practice or internal medicine?
Mike, you're muted.
Yeah,
You're muted.
what I can tell you from my experience in that is that, much of that, so blood pressure measurement, yes. So we find that and have found that improving the quality of blood pressure measurement, both in and outside of the office setting, is something that OBGYNs are more than willing to do in general. And there's a large effort to make sure that women who are pregnant in the postpartum period have access to out-of-office measurements to ensure postpartum blood pressure checks if they've had any issues at all. So critically important. But to answer your question, I think it's really more about the culture of the organization as far as, and this varies regionally and within organizations in a region, whether or not an OBGYN department and their physicians there are comfortable with managing hypertension in pregnancy and outside of pregnancy. I think it's mixed. And in general, I would say it's not something, and this is anecdotal because this is from our experience, a lot of experience, but that some OBGYNs are comfortable, but it depends on their organization, whether they have an infrastructure set up for experts to consult in the management of hypertension, or even primary care willing to manage hypertension in pregnancy. So there are so many variables. I can't generalize and say what the answer to that question is, other than it's variable. And it's certainly something that's needed. And again, we like to start with the simple things like measurement, whether or not an OBGYN is willing to manage primary hypertension in their patients who don't have another primary care physician is a really big problem and an issue. So if there's an infrastructure set up so they can refer that out for management of primary hypertension, that it's great when that happens, but there are still many who are not comfortable doing that. And I think, again, a lot of variability around that. So a tough one to answer. Well,
So, I mean, Bill, you bring up a great point, and we learned this earlier in 2021 when we had a presentation by an obstetrics and gynecologist here from the Bay Area on the fact that this is undertreated. So I don't know what other organizations are doing, but what I decided to do at our organization is we're meeting with our OBGYN entire staff in about 2 weeks. The cardiology department, we're going to get together with them and go over hypertension guidelines and some of the new clinical updates. And our goal is to increase and referrals directly to us and our pharmacy-led hypertension clinic. And I think there's a need for this everywhere to increase this collaboration, because Dr. Balmer, you're absolutely right. These patients are being missed. And unfortunately, we see them later in life when they're presenting with complications from hypertension, and with that history of, even just hypertension during pregnancy or preeclampsia, and nobody thought any more of it for many years.
I'm happy that we have our Los Angeles co-chair with us today, Dr. Keith Emmons, who is the medical director for CenCal Health in Santa Barbara, California. Wonderful to see you, Keith.
Hi, thank
The
you.
floor is yours.
Thank you. I want to go back to a comment that Scott Flynn made. And also, Mike, you brought it up a little bit too. And that was your going back to addressing the underserved populations. You mentioned, Mike, that you had met with the Association of Black Cardiologists and the NMA, and I know some of those members. But I want to ask you, we either pay now or pay later, and the bill paying later for the complications is much bigger. So my question to you is, have you thought about a special program where you can go out and actually just go into the different offices and clinics that are serving your underserved population? I think that it was Scott that mentioned you cannot move the needle unless you move this population. Have you thought about going out and just going out, because the lack of resources, both from the provider's level as well as from the recipient, the patient level, is what's holding you back. So we have to think of outside the box, new ways, instead of just having meetings to go out and say, we're going to give you this program, we're going to institute this program, we're going to supply the resources needed for this program to start moving the needle in this population.
So great question. I'll give you a couple examples and then I'll turn it over to Karen to talk about what we're doing on this issue in Chicago. But we believe in this so strongly, how important this is, and that data, having the data in the hands of the providers and care teams is so important, that we have agreements, contractual agreements with two of the largest population health vendors in the country that track metrics and chronic conditions across the board, that can reach close to 60 million people that exclusively are in federally qualified health centers or community health centers across the country. So disproportionately impacted, historically marginalized communities, to the tune of about, like I said, close to 50, 60 million people. We entered into those agreements so that we could help figure out a way to, wherever they have that data and those dashboards, that we could bring to them, and as it relates to hypertension, the metrics that I've talked about. And that's why we're working on an automated or digital version of our program to get into the hands of all of those people with data. And we're trying to, we plan on studying that more this year. Absolutely a critical component. And we have been collaborating with the National Association of Community Health Centers, so the membership organization of all community health centers in the United States, in these communities and that manage these populations that we're talking about. They have about 1,100 health centers across the country, tens of millions of people in them. And we've been working with them for 7 years to try to answer these questions. And now with Million Hearts and CDC and the National Association of Community Health Centers to try to figure out what we can do. We go in virtually now with webinars. We were going hands-on in trying to do this in cities like Nashville, in Atlanta and other cities. And now we're working in Chicago, trying to do something similar. Karen, I don't know if you want to just briefly talk about what we're trying to do on the West Side.
Yeah, I'll just mention that we know that where we sit in Chicago, where the Chicago AMA offices is in Chicago, is one of the more affluent parts of the city. And if you go just 1 mile west or 1 mile south, you have people who have a shorter lifespan. And we know it's from structural inequities that have existed for decades. So we said to ourselves, well, what are we going to do? To your point, Dr. Emmons, you got to go there and sit down and understand and figure out what can we do. So we are engaged with the communities on the West Side, and we acquired the devices. We acquired 1,000 devices last year. We got another 1,000 ready to go, the home blood pressure devices, to give them out to citizens. But we have to accompany that, of course, with the education. What do you do with it, right? You got a busy life there, right? And so how are you going to carve out the time in the morning and the night to take your blood pressure? And then how do you get that information to your primary care physician? So we also recently, Mike made the connection with community health workers, because we thought, maybe it would be helpful for some of the residents to have someone locally be able to go to their home post-pandemic, right? And say, hey, you got this device. you had some education, but I'm sure you have questions, right? It's not something that you just know how to do every day, right? So we're now engaged with training a cohort of community health workers
Good.
how to help someone take their blood pressure at home. So we're trying. We know we have a lot more to learn. We go there with all humility, but we think our offering might be in this area of self-measured blood pressure, providing the devices, providing the education, and building that cohort of community health workers.
That's good. I'm from Chicago. I know the communities that you're talking about on the south side and the west side. I think the next great study that you could do is after, and this would be a massive input of resources, is to show how this program can work in this population. That would be impressive. And in doing that, I think you have to address some of the baggage that and it was mentioned by Mike a little bit, I think earlier on, some of the baggage from the AMA. When I was training in Chicago as a resident, and I said I wanted to join the AMA, I had to attend, and they said, why? They don't do anything but, look out after money. So you have to address that and address the fact that you have a new outlook on life now. You have a new outlook on patient care. You have a new outlook on providing and remedying the equities of or lack of equity of healthcare. And if you come with that message and you come with that resource, I think that you'll have the next great study to show a huge change in that population.
Thank you, Dr. Emmons.
Thanks, Dr. Emmons. And now, as we approach the top of the hour, Hattie will unmute herself and ask the last question, and then Dr. Balmer will close for us.
I just want to urge everyone to think about what we can do from a federal public policy level. We all have great allies at the federal level right now. We've got the data. We can see in CDC Wonder that with this wonderful new data that's available to us, that hypertension, heart attacks, and strokes are killing more Americans than the cancers that we're screening for, starting in the decade of 35 to 45, at least from the analysis that we've done. So we need to think bigger. We need to think, what are the financial incentives to address the very deep issues that Keith Emmons was just raising? You can't do it one medical center at a time. We have to have a change in public policy to say, here are the resources to actually do this. Where Keith is saying, you can't go to these underserved areas and say, well, we really want you to hit these targets when you do not have the equipment at hand. It's wonderful to have these, foundations coming in and making contributions in targeted ways. But really, shouldn't our federal policy be, we know how to control cholesterol, blood pressure, blood sugar. And if we do that, we know in this data behind me that really, really quickly you can drop heart attacks by 1 in 5. Scott Flynn helped me do it in our original pilot community in San Diego. And Scott, I know you said you have to go, but I think we need to really think about, let's change the public policy to go with the really nice knowledge base that we've built. Scott, you're on.
Yes, and that is one of the pillars that the CDC is looking at for sure. That government interaction, be it local, state, or national. How do you do that? How do you better get the resources you need to make the efforts you need to change the current situation we're in? This is unacceptable.
Well, I think that concludes our program today. It is just after 6 o'clock. We've had an exciting program today. Lots of new information and incentives. And perhaps we leave the program with a discussion of carrots or incentives for enhancing this program. I think we've got a lot of motivated people who want to improve this. We're all interested in improving health, but as Hattie pointed out, sometimes a little bit of carrot at a federal or national level, or certainly at a state level, can drive the system in a direction that this works. We know what our healthcare system operates on. It operates on cash, and some type of incentive that is available to a healthcare system or a provider goes a long way. We can tell you as soon as they change CPT codes, efforts change in a practice, policy changes quickly. So that may be an additional way to work with partners along the way to see if there is a way of getting that. The so-called pay for performance has always been talked about. We've never really gotten there in many ways, but there's certainly an option for that. We certainly want to thank all of our speakers today. And we also want to tell you there is interest in California in the programs that we discussed today. We will provide you with lists of individuals or participants today who expressed an interest in looking more closely at what the CMA has to offer in these programs. And perhaps some of the individuals on today may eventually work with an agreement with CMA for accomplishing some of the enhanced tools that were discussed today. We're certainly happy to have everyone here to introduce new partners into our group and system. All of us, I think, have the same goals that were expressed by one of our founders to not compete with each other, but compete for improving health. And I think this goes a long way to doing that. We want to thank everyone for their participation in today's program and wish you the best of luck. And hopefully tomorrow will be a little bit better day for COVID as we go one day at a time. And we'll be able to then start focusing entirely on this chronic disease that has been with us for eons. And we do have outlined, I think today, a couple of encouraging ways of improving that. And we look forward to that improvement of the goals that all of us have of our organizations, ultimately improving healthcare for all individuals in the US under our care. Thank you everyone for attending and have a great afternoon.
Thanks everyone. And Mike and Karen, I will connect you to Keith by email